Hello, and thank you for tuning in. My name is Elizabeth Burnham. I'm your educational guide here at Balcones Pain Consultants. Today we will be learning from Dr. Matthew McCarty, interventional pain specialist and co-founder of Balcones Pain Consultants, and Dr. Cory Peters, physical therapist and CEO of Outcomes Therapy. Welcome. Dr. McCarty, what made you want to get into your profession?
Chronic pain. I loved helping people with problems that just would not go away. I enjoyed the idea of doing interventions and seeing immediate benefit. I also enjoy working into the harder problems and doing the more advanced therapies like it was SI fusion or minimally invasive spine surgery on the spine, treating lumbar stenosis, spinal cord stimulation, DRG. Overall, I like the relationships you build in a chronic disease practice with patients coming back month after month, year after year, and seeing incremental improvement in lifestyle and functional improvement. Those are pretty much the big reasons.
That's wonderful. And Dr. Peterson?
So I was in the Marine Corps right out of high school at ripe age of 19 years old. Enlisted, and during my service I sustained a hip fracture which led to a surgery and ultimately a medical discharge from service. After that I decided to pursue physical therapy because my passions were fitness, anatomy, and then I was just in love with medicine, particularly physical medicine, so physical therapy seemed to be kind of the right choice for me. And then I also discovered during my practice in education the healing properties of your body, how you can heal without taking medications and injections and sometimes surgery. And it just kind of suited me because, I really like to hone in on our own physical capabilities and being able to manage some symptoms ourselves, especially if you catch it early enough.
And speaking of healing, what conditions do you see most frequently?
In my practice, I see mostly back pain, neck pain. I see patients who had surgery before and who didn't get better from the surgery with persistent leg or arm pain. And I see anywhere from fibromyalgia to migraine headaches, but the majority of it is the lumbar spine. Very common problem in the general population. 80% of people will have back pain at some time in their lifetime. So yes. See a lot of that.
Absolutely.
And Dr. Peterson?
Probably the same. In my practice, we treat a variety of conditions from foot and ankle issues, knee, hip issues, and then of course the spine and SI joint is kind of my specialty practice personally. So apparently that's what I typically get, and I love it. A lot of times it boils down to postural problems. Of course, as a physical therapist, we are really concerned with movement and considered, the movement specialist. So seeing how one joint moves on another is really important. We operate in a term called regional interdependence. So we look at the source of the pain, which it might be your knee or your hip or your back, and then determine from areas above and below where any restrictions or impairments might lie and address those. But to make a short story long, typically spinal issues from neck pain, and again, with the headaches too. We do a lot of headache work.
Very common.
Yeah.
And what advancements have you both seen in your fields of care?
Well, we've seen huge advancements. I've been doing chronic pain management for 20 years. Before that, I did anesthesia. I'm a board certified anesthesiologist and did a fellowship in interventional pain in the University of South Florida Medical School. For probably 13 years, we saw my practice was primarily composed of injections, spinal cord stimulation, and in the last 7 years we've seen huge advancements in spinal cord stimulation for leg pain, arm pain that just won't go away, back pain that won't go away, diabetic peripheral neuropathy that just plagues people with pain at sleep. But more importantly, we're seeing minimally invasive spine surgery become important. Specifically, we're seeing treatment of lumbar spinal stenosis. That's pain that someone gets when they go from a sitting to a standing and they have butt or leg pain. We're doing decompressive surgery there I could do in an outpatient environment. It takes me 20 minutes to do the procedure. We use spacers, or we can do mild procedure. And then sacroiliac fusion. And SI fusion is a problem that probably 20% of the back pain, it comprises 20% of back pain as a problem. And people who've had fusions, lumbar fusions, they have 75% of them at some time in their life will have some form of SI pain because you lose mobility segments, and then that becomes problematic. So we're seeing fusion of the SI as being a real new procedure that's helping people.
What I particularly love about Dr. McCarty's practice is they go to more of a non-pharmacologic approach, which I think is one of people's biggest fears whenever they're referred to a pain management physician, because they're just thinking, oh, they're just going to drug me up. And there are some that do that, and hopefully, you know, with the whole opioid epidemic being front and center in the media, we can see kind of a, you know, drastic change we have seen it over the last few years. But that's what I really love about your practice in particular.
Well, thanks, Cory.
So I feel confident in referring to Balcones Pain Consultants as, you know, kind of
things have really changed, haven't they, over the years?
They have.
I've seen such change. After the decade of pain, opiates were widely prescribed in Austin and all over the United States. And gradually we've seen a decrease in morphine equivalents prescribed, and it's been challenging for some patients. I want to make it clear that, you know, I'm not afraid of prescribing opiates when it's needed, but I only do so if, for instance, the patient's having pain, they can't sleep at night. You know, if you don't sleep at night, the wheels come off and you have problems. So we'll utilize opiates in those scenarios, and judiciously otherwise, but it really has changed. Our dosings are very low. And fortunately, with all the minimally invasive evidence-based therapies we offer now, we don't need as many opiates. These patients get better, and I can send to you, Cory, these sacroiliac pain patients who there's great evidence for chiropractic care in getting SI pain taken care of. Sometimes it can return, but many times it's the therapy that's needed. So I really like to work with a chiropractor, and you do a great job.
Well, thank you. So on your point too, as far as, you know, there's always, you know, pharma is definitely necessary, and there are always different situations that might call for it, you know. And then you touched on how, you know, sleep is so important. I recently read about how whenever we lose an hour every year, and this is billions of people that were part of this study, hospitalizations, so incidence of heart attacks goes up 25% from a normal day in the ER. And whenever we gain an hour of sleep, it correspondingly changes. So there's less admissions because sleep is so important. So getting people recovered and able to sleep without pain is so important.
For sure.
But and to your question, what kind of advances have we seen? So in the field of physical therapy, I mean, we were kind of born out of post-polio and, you know, World War II, you know, traumas and getting people back and recovered and rehabbed, and it's progressed and to a point where, you know, we are much more involved in the orthopedic space. You know, I went through my orthopedic residency in 2014, and you know, there we learned a lot of spinal manipulation. We brought a lot of different tools into play to help people recover and get out of pain quickly, and one of those is dry needling. You know, a lot of people associate dry needling with only trigger points or muscles. The practice that I perform, it does basically, we do muscles, we do ligaments, we do fascia, tendons. We can actually get close to neurovascular bundles and help, you know, decrease that pain response in conjunction with electrical intramuscular stimulation. We also implement deep tissue laser therapy, which, I think we're one of the few clinics in the Austin area that actually performs deep tissue laser therapy using a class 4 therapy laser, which it uses basically a process called photobiomodulation, where it introduces photons into the mitochondria of the cell and allows for increased energy production. Different substances that are triggered also increase the blood flow, and obviously the healing properties of the blood kind of help. So it's really good for pain and inflammation. And then we've also recently introduced into practice blood flow restriction training and therapy, which is kind of interesting because you kind of starve the muscle of blood, and just the physiological effects increases muscle mass, especially in geriatric population, significantly. So
interesting.
Yeah, it's come a long way from treating post-polio patients, so.
So we've seen a lot of advancements in both pain medicine and physical therapy.
Yeah.
It's wonderful.
It's been good.
Yeah. Dr. McCarty, you had mentioned the SI joint fusion. What is sacroiliitis?
Well, sacroiliitis is a condition, as I said, that probably comprises 20% of back pain patients. Sacroiliitis is where you have movement of the sacrum against the ilium, causing pain. It can also be caused from some autoimmune inflammatory disorders, psoriatic arthritis. It can cause some erosions within the SI joint. The symptoms of sacroiliitis are patients who have pain when turning in bed at night. And I have a model here I can show you. When you turn at night, you're moving this ilium against the sacrum, and that itself can cause pain. So the sacroiliac joint is one of the largest joints in the body. We have two of them, one right and left, and it's when this moves against this sacrum. So the things that can bring on sacroiliitis are, I just saw a woman a minute ago who had a hip replacement, and one femur is longer than the other. So when someone walks, if they have a longer hip, they might have a gait like it's rocking.
Kind of creating a shearing effect.
Right, and that can cause it. Pain climbing stairs, you can bring that on. And just if there's a fusion, and I talked a little bit about that, lumbar fusion, where you have a restriction of movement of the lumbar vertebrae, then this joint here is the only one that can move. Normally it only moves about 3%, 3 degrees roughly, and it moves like this in the pelvis. So what we see with sacroiliitis is those kind of pain conditions where they're pain walking upstairs, turning in bed at night, any kind of one-legged activity, playing tennis, and we do a series of exams in the office to bring on that kind of pain. And then a definitive diagnosis would be doing an injection of local anesthetic inside the joint under fluoro and getting 85% relief of the pain. And we can say, okay, that it's very likely, and that's a temporary relief, it's very likely that the pain's coming from the SI. And we do that on 2 occasions. But this is usually in conjunction with chiropractic care, physical therapy, and we like to really give that a very deliberate and long approach to see if that can benefit. So sacroiliitis is real common, and therapies for it include the injections of steroids, which we tried, but I haven't found that to be long-lasting. And then when it's not, we'll do a SI fusion, and that's what these 2 screws represent here. Is that we a patient who never really gets better despite 6 months of supervised therapy and home therapy, activity modification, who continues to have pain even after a diagnostic and steroid injection in the SI, who has no other reason to be having SI, this kind of pain, and we will scan their pelvis and do hip x-rays. They are a good candidate for SI fusion. It's a 20-minute procedure done downstairs in our outpatient surgery center, where I put 2 screws in the ilium, and it goes into the actual sacrum, in the alar sacrum, and it fixes the joint where it doesn't move any longer. Patients are sore for about a week, but generally start feeling much better and are able to go back to activity. So.
And that's an outpatient procedure, correct?
Right.
So they go home the same day. They're not
Right.
staying overnight in the hospital.
Yeah, all insurances cover it. Medicare is the one that leads the way. It's very common as we age. They require 6 months, as I said, of active therapy. So I would send to Cory, Dr. Peterson, for his therapy on this, and he would teach them how to do home therapy. He might also teach them activity modification, and would give that a real good try. And if the pain just keeps coming back because there's movement here in this joint, that's when SI fusion is indicated.
Okay.
Yeah, it's pretty remarkable to me. When you take away movement from certain parts of your body, it's gonna find it somewhere else.
Yep.
So
like a fusion.
Exactly.
Having this, yes.
The SI joint
Yeah,
issues.
I see
that's
a lot of patients with that.
hypermobile. And then when you fuse that, I would imagine that could probably open up some positive effects to increase hip mobility, which is naturally supposed to be a mobile joint.
Right.
And I would imagine that you might see a lot of hip tightness if you do have excessive motion in that SI joint, because it's just kind of a cascading effect in your body. You've got those alternating points of stability and mobility, and it's going to find it somewhere.
Right.
So it's pretty amazing to me just to see how your body kind of tries to self-correct.
Yeah, I'm glad you mentioned that. Usually patients that present with sacroiliac pain will have pain across the top part of their buttocks. They'll have growing pain, and that's, to your point, the muscles in the front of the leg are trying to compensate for the pain going on back here,
providing stability.
And I've even seen it down below the knee. It doesn't often get there, but it can get down below the knee. The radiating pain. And so all that is taken away by a diagnostic block, but that's a very temporary approach, but one that's needed to diagnose it.
Absolutely.
So when someone starts having these symptoms, what would you suggest that they do?
Don't wait. I think the biggest mistake that people make is they wait for it to fix itself, and it could present for months, turn into a chronic pain issue. And then, as we know, with chronic pain, there's some cortical changes in your brain that occur, and positive feedback loops that just keep that pain cycle going even whenever the stimulus is relieved or taken away.
Yeah.
So don't let it get to that point. Seek, go to your primary care physician. A lot of insurance plans like PPOs will allow you direct access to, people like Dr. McCarty. Of course, do your homework on who you're going to go to. I highly recommend him, and also his associates too, because they all very they have the same ideologies.
Right.
Whenever it comes to intervening.
Yeah.
But I'd say just don't wait. Don't let it progress.
I agree. Many people suffer with low back pain for a long time, and I see chiropractors and Dr. Peterson will pick up on, hey, this is sacroiliac pain. And once they understand where the pain's coming from, and not from the spine, not from the disc, not from an entrapped nerve root, it really helps guide the therapy, and we can get them in that track to try to focus in on our treatment earlier. So.
Yeah, it definitely takes a multidisciplinary approach to relieve a lot of these pain syndromes throughout the entire body. But I had a thought and it escaped me.
Yeah. So I think the combination of working closely with Dr. Peterson, physical therapy, getting a patient a real opportunity to get better on their own can help take care of SI pain. What percent has to be fused? It's difficult to really give you that number. A lot of it depends on how much movement. I have seen movement in young women after having a baby. The ligaments become lax and they can have a little SI pain. Usually those ligaments will tighten back, but I've seen people with demonstrable distance between the ilium and the sacroiliac, and they have significant pain. So. And as I mentioned, total knee replacement, total hip replacement, all shortens the leg, causing a leg length discrepancy and maybe a rocking motion normally, which then loosens this interface between the sacrum and the ilium. So that can often be the reason why. scoliosis. You probably have seen that before.
Oh, yeah.
That can also tilt the hip up, causing some sacroiliac pain.
A lot more pressure on one side. Yeah, absolutely.
And
sitting on a fat wallet. I was guilty of that a long time ago, and I remember there was some research that came out long ago. So now it's front pocket wallets only for me. You know?
Well, anyway, I want to thank you for joining me and being able to talk a little bit about sacroiliac as a team approach, sacroiliac pain as a team approach, because that's what it takes in these care models. So
I definitely
look forward to working with you further.
Me too. Really enjoy it. And just to clarify, like whenever Dr. McCarty is talking about chiropractic care, we do a lot of joint manipulation. So we will essentially pop the joint, which a lot of people would refer to as an adjustment. It's just a little bit different philosophy that us as physical therapists have, and that's not our primary approach. We also include the exercise component, stabilizing basically postural muscles, using postural muscles to help stabilize certain areas that are hypermobile. And again, kind of looking at that alternating and cascading event of stability and mobility, and seeing where there might be disruption in that chain, and then addressing the problem, hopefully at its root cause. Of course, other impairments might, it's kind of like an onion sometimes. Or whack-a-mole, we fix one problem, and then they're like, oh, well, I'm having some pain here, and it's like, okay, well, let's look at the impairments that are causing that. So it's a lot of fun. We get to kind of investigate as a team what's happening and problem solve it. So love problem solving.
Thank you.
Absolutely. Thank you, Dr. McCarty.
Thank you both for joining us today. I think we've learned a lot. If anyone is interested in learning more or booking an appointment online, make sure to click the link below.